Next is about seizures and epilepsy. Now, seizures, that word seizure, is defined as a sudden, uncontrolled burst of electrical activity in the brain, and it can cause changes in the behavior, movements, feelings, and level of consciousness. And seizures are the manifestations of abnormal, hypersynchronous, and hyperexcitable discharges of cortical neurons. See, seizures doesn't mean only convulsions. That's the important thing. Convulsions are where you have an established level of impaired consciousness, whereas even the changes in the behavior, movements, even emotional changes also are categorized as seizures. Classification of the seizures were of different types since a long time, like there are many different sorts of classification earlier, but the latest classification, the simple basic classification based on the International League Against Epilepsy 2017, this is the latest of the classification, is again categorized into three categories: focal onset, generalized onset, and unknown onset. In the focal onset, again we have two categories, where the patient's consciousness is impaired and the patient's consciousness is not impaired. And there again you will have this motor and non-motor. Motor is where there are the signs of motor activity. Non-motor, where there are no signs of motor activity, it will be only the sensory. There again it could be again subclassified as a focal or bilateral, tonic and clonic. We will go into the detailed classification next part. Generalized onset is mainly impaired awareness, like chances of having a non-aware conditions would be, or patients who have a normal awareness in generalized onset is comparatively lesser. And it's again categorized as motor and non-motor. Non-motor also is called as absent seizures. And unknown onset, where it's not really known, also the real origin is not known, where again you have motor, tonic and clonic, and the other varieties. Now, a detailed classification, same the classification is expanded, and that expanded version would be, in the focal onset again we have motor onset. The features are named as automatism type of convulsions, atonic, clonic, epileptic spasms, hyperkinetic, myoclonic, tonic, and non-motor onset. Autonomic again behavior, and behavior onset cognitive, emotional, and sensory. In the generalized onset again the same motor, tonic, clonic are the common for both. In the generalized and the focal, the difference is in the focal, when these signs occur, they occur in the limited area of the body. Generalized when it occurs throughout the body. And in the non-motor, absence apparatus again typical, atypical, and myoclonic, and eyelid myoclonia. And unknown onset again same issue, is somewhat what we call as expanded definition, expanded version of the classification. And of these seizure types, they are defined now clearly. The words are very clearly defined now, where there is no scope of confusion. Earlier, because the words were overlapping, there was a bit of confusion now. And the definitions are: automatism, the first one, is defined as the act which is done by muscles without any control of the mind, such as spasm, or a reflex action, or a convulsion, or an act done by a person who is not conscious of what he is doing. That patient has not unconscious, patient is not unconscious, but he is doing some activity which he is not aware of. Such an act is called as automatism, and this was defined by Lord Dunning as it can be something like sleepwalking, or the injuring himself also can be the clinical evidences of automatism. Then another of the word which is we have already come across is atonic seizures. Atonic seizures are the type of seizure that causes sudden loss of muscle strength, and seizures also are called akinetic seizures. These are like something like a drop attacks or drop seizures, also named as a drop attack, or a drop seizures. Characteristically, the patient remains conscious and there is a sudden loss of movement, and hence there could be a situation like a head may drop, or there could be loss of muscle control, or patient may slump and fall back, forwards, or any such activities. Suddenly, where the muscle tone is reduced and hence there could be some abnormal situations. Such conditions are called as atonic seizures. It's not necessary that the patient should fall off every time, but the patient may feel those symptoms, and this also is named as a Gastaut syndrome. Then the clonic seizures are due to they produce a repetitive and uncontrollable jerking of the body parts. Either it could be limited when it is a focal, when it is generalized, all the parts of the body are involved, that's the generalized, and they can occur in one side of the brain, that's focal, or both sides as generalized. During generalized clonic seizures, the sufferer is usually unconscious. While in focal seizures, he may retain some level of consciousness. The patient may be partially conscious or fully conscious in the local. So there is a typical, in a generalized conditions, jerky movements of the body, froggy saliva could occur, and the eyes also may be blinking. That's typical of a generalized clonic seizure. An epileptic spasm is another variety of the seizures, and it's very brief, short, lasting for 1 to 3 seconds, where there could be flexion, extension, or both of the proximal or truncal muscles, like a limb, upper limb or lower limb may have sudden movements of flexion and extension, both. It's not only a jerk. And these may occur in clusters, like repeatedly 1 or 2 of such movements would occur every 5 to 10 seconds with a gap. And this also is called as salam seizure. Now, like as you see in this, a person sitting on the table, maybe suddenly the arm as well as legs may be flexed and extended. Suddenly there could be repetitive such movements for a short duration, 1 to 3 seconds, and then it may be repeated at a gap interval of 5 to 10 minutes. Then hyperkinetic seizures are those which are characterized by sudden movements occurring in the body, either in the proximal limb or in the core part of the body, where there could be irregular, sequential, sudden movements of the body, and most of the times these are observed when the patient is sleeping. Like the same movements may be repeated, like arm may be lifted up, or it could be suddenly the patient may get up. It's not that the patient may awaken from the sleep, and that kind of a movement which is occurring in between, again the patient goes back to the sleep suddenly. These kinds of movements are called as hyperkinetic seizures. Then myoclonic seizures are a relatively common type, more common type of seizures that produce uncontrollable lightning fast muscle movements. That when the patient attempts to move a part of the body, there will be sudden uncontrollable movement, spasm of the muscles would occur. Patient may even feel the pain, pitchings also may be seen in the muscles, and mostly it's seen in younger age, in between age of 3 to 12. These kind of seizures are most frequently seen. Tonic seizures are which can produce stiffening, tension or flexion of the body and extremities, which can cause the sufferer to fall backwards. Now, the tonic and clonic, the difference is in the clonic there will be jerky movements, whereas in the tonic the muscle will be held in a tonic condition and there may not be a movement as such, and the patient may have a whole body stiff as such, and the position also may be bent depending upon the strength of the muscles. What's described as dhanustamba in Ayurvedic text. There can be incontinence also. Body would be stiff. Patient may have a sound produced due to that sudden spasm of the respiratory muscles. And the other non-motor focal onset seizures, the other variety, autonomic seizures, are mainly characterized by autonomic nervous system symptoms like either nausea or sudden pulse rate being increased or reduced, either bradycardia or tachycardia occurring suddenly for a short duration and then becoming normal, without being aware of any of the activities and without having any specific causes for that. Then the behavioral arrest seizure is a impaired awareness where the patient may freeze up. Persons may, for a moment, person may not be able to do any activity, but he is not unconscious, but he is not aware of that. That kind of a situation, or many times persons may repeat the same words or phrases without being aware of that. and for a short duration. Then again the patient becomes aware and then he may continue. These are considered as behavioral arrest seizures, where the patient doesn't lose the consciousness. Patient would be conscious, but all of a sudden there is a cessation of the activity or maybe repetition of the activity. A focal cognitive seizure is a alteration of a cognitive function where the patient is not able to sense properly. Suddenly there could be a impaired sensation which can result in it's may be present as a forced thought. The patient may have a sudden thought like some abnormal thought, hallucinations like sudden loss of memory, or he may have a sudden feeling like he is unfamiliar with the situation around him, though he is otherwise in the same condition. So many times the patients may miss the path. When the person is moving around, he may miss the path, he may fail to come home as such. That's called as also deja vu. Or many times it could be the other way. A patient who is in a new condition may feel more familiar, and again there again he may have a confusion there, and this is called deja. So deja and deja vu are the two technical terms used for that feeling of unfamiliarity and feeling of familiarity. Or the patient may feel like dissociated, he is not corresponding to the situations, like he may feel behave like as if he is in a different situation. Or patient may have anomia. Anomia is where the patient is not able to recollect the names momentarily. For a moment the patient may not be able to recollect the name. So these kinds of the changes are also called as cognitive seizures as such. Then seizures presenting with an emotion or the appearance of having an emotion as an early prominent feature, such as fear, sudden joy, euphoria, laughing or crying. The laughing and crying also are named as gelastic and acristic, the technical terms, not important. It also could be the presentation of some seizures, and these also have to be identified as seizures. Sudden depression, sudden laughing and so on. Sensory seizures are where the patient may have abnormal sensations, smelling something which are not there, or tasting things that are not there, or hearing or clicking, ringing sound, or a person's voice that's not there. Olfactory sensations also, smell can be presented as, or auditory phenomena like buzzing, ringing, drumming, etc. Different tones could occur. This about the focal type of the onset. Generalized onset, very similar to the focal types, except that the patient may have impaired consciousness like atonic, tonic, clonic, and tonic, clonic, myoclonic. These are almost similar. Then a generalized non-motor absence seizure is a type of seizure. That's it's also earlier it was called as petit mal. Now that kind of a term is not used. That causes a person to stop their activities, stare blankly, and be unresponsive to speech. Absence seizures are a type of dialectic seizures. The difference between an absence seizure and personality disorder is a absence seizure person would be conscious, but he is not aware of the things, like he never knows that he has stopped the activity somewhere in between. Whereas in case of the behavioral changes, the patient knows that he has done something of that sort, where temporarily the cessation was activity was known. So that's the difference. In absence seizure, patient suddenly or a person stops the activity suddenly, stares blankly for a moment, and the time could be varying, and at that time he will not be able to respond to the stimuli. If somebody calls or somebody speaks to him, he will not be able to feel that. But the patient would not, after the patient recovers, he doesn't know that he had such an incident earlier. That's what we call as absence seizure. Or during these situations, the muscle tone also may change, and hence the patient may have some specific type of movement like blinking, chewing, or hand gestures, movement of the hands, etc. And these may last up to 20 seconds. That's around the time average. Then a myoclonic absence seizure is a type of generalized non-motor seizure that's characterized by sudden onset and offset of and during this patient child's neck, back and arm may become stiff or rigid. For a moment there could be a sudden rigidness or stiffness, mostly seen in children, and this is called as myoclonic absence seizure. Then eyelid myoclonia is the other common type of the seizure type, where the patient may have repeated jerks of the eyelids. Eyelids may have some feeling tremors like, or eyeballs may roll upwards and the head may move slightly backwards. This can moment again for a moment like 6 seconds and may occur many times in the day. So these are the different types of the seizures which need to be identified. So seizures are not only a generalized convulsions, that's all the important thing. Now with this basic introduction to that word seizures, we'll go into specific disease conditions. One of the most common type of the seizure activity which we see in the clinics would be the febrile seizures. Febrile seizures are defined in current definition is a seizure occurring in a childhood after 1 month of age. This is important because when it occurs before 1 month of age, it's categorized as a habitual seizure activity or paroxysmal seizure activity, which will come to that later. And it's associated with the febrile illness. Essentially, there should be fever. And again, in a febrile illness, where the central nervous system inflammation or meningitis is not the cause, then it is called as febrile seizures. Meningitis producing the seizures is not categorized as febrile seizures. That's the important thing. So, before you name any condition as a febrile seizure, you have to rule out the possibility of central nervous system involvement, and without any previous neonatal seizures. When you say neonatal seizures, that's which occurs before 1 month. If the history is that the patient has a seizure before 1 month of age, that's called as neonatal seizure, where the approach is slightly different. And I will come to that part. And are symptomatic seizures, other conditions like epilepsy are ruled out, then it's called as febrile seizure. So when you say febrile seizure, it has to be categorized into, or it has to be considered after ruling out the other primary causes. Then these again are categorized into two categories: simple febrile seizures and complex febrile seizures. Simple febrile seizures are generalized, last for less than 15 minutes and do not recur within 24 hours, then you call it as a simple febrile seizures. So to categorize a condition as a simple febrile or complex febrile, you have to observe the patient for at least 24 hours and also assess the duration of the seizures. If the duration of the seizure is less than 15 minutes and it doesn't occur repeat in 24 hours, that's categorized as simple febrile seizures, where your approach to the treatment and diagnosis would be different. Whereas a complex febrile seizures are which are prolonged and which may recur more than once in 24 hours, or they are focal, where the patient's symptoms are limited to one part of the body, not generalized. So if there is a generalized condition, that's categorized as simple. If there is a focal, then it's called as a complex, which has to be considered as complex. Where the basic issue is in a complex febrile seizure, the diagnostic exercise has to be more elaborate, and the patients are more prone for prolonged complications as such, and hence you have to be more careful. Whereas simple febrile seizures, they are purely due to the fever, and once the fever subsides, the patient may be considered as a normal and there is no need of prolonged treatment. And most of the times the complex febrile seizures may have suggest about a serious disease condition such as meningitis, abscess or encephalitis, and hence thorough investigation would be necessary. Now as far as the febrile seizures are concerned, the statistics in India, between 5 to 10% of Indian children develop febrile seizures by 5 years of age. This is based upon the statistics analysis. Of course the percentage may be slightly more than that. And the incidence also would be quite high, varied in different geographic zones. In the Western countries, the percentage of seizures are maybe slightly more than what we see in India. Then the children present with the febrile seizures, they have to be carefully assessed if they have a family history of febrile seizures, like if the patient's spinsters or maybe the younger or elder brothers or so on also have a history of febrile seizures. You have to be more careful. There could be some genetic pathology. If the temperature is very high, usually Febrile seizures do not occur before the temperature reaches 102 degree Fahrenheit. If the temperature is high like 103, 104, there again the risks possibility there could be damage to the brain tissue, and that has to be considered as a risk factor. If the child has a developmental delay, congenital pathologies, or where the growth is not normal, in these conditions it has to be considered as a high risk condition. And if more than two of these are presented, then it could be that the patient may have a high risk conditions. Then another of the issue is maternal alcohol intake and smoking during pregnancy, which also increases the risk by two-folds. Then if the child has recurrent febrile seizures, if the child has repeated episodes of febrile seizures, then there again the risk factors will be considered as if the child is very young at the time of the first febrile seizure, and consequently the febrile seizures they tend to occur even at a relatively low temperature. See, usually the seizures would occur only after 102 degrees Fahrenheit. Some of the children may develop that episodes much earlier, maybe by around 100 degree Fahrenheit or even lesser than that. That's considered as a risk factor where you have to be more alert, and a diagnostic exercise has to be elaborate. If there is a family history of febrile seizures and particularly first degree relative, that's directly the brother or sister, then brief duration between fever onset and initial seizures. See, most of the times, characteristically, the seizures would not occur the moment the patient has a temperature. It takes somewhat 3 to 4 hours for the seizures to occur after the patient is recognized to have temperature. But if the seizures occur immediately after the body temperature rises, that also is suggestive of a risk as such, which again requires some elaborate conditions. Now, all these clinical clues are quite important to decide like how to approach the patient of febrile seizures. Now, the important is a simple febrile seizure without risk factors, the total approach is totally different. If the patient has a risk factor, you have to go for a thorough investigation and confirm the origin, and the treatment also has to be maybe more energetic for longer. So from that point of view, clinical clues are very important, and these clinical clues are quite vital. If the patient has multiple initial febrile seizures during the same episode. Now, if the patients do not have a risk factor, this is important. If the patient does not have a risk factor, or any of the risk factors are not there, and it is the first episode, as per the American Academy of Pediatrics on emergency medicine, very clearly it does not recommend ordering laboratory testing for a child with a simple febrile seizure whose mental status has returned to baseline, that the child is normal within a few minutes, like, or even EEG also is not necessary in the routine evaluation of a child with a simple febrile seizure. So, simple febrile seizure with the low risk factors, absolutely there is no need of any thorough investigation. Whereas if the patient has a complex seizures and the risk factors are there, then a thorough investigation is necessary and the underlying diagnosis has to be made accurately. Now, the treatment in a simple seizure would be, that's the important issue, simple febrile seizures. During active seizures, you have to manage to ensure that the patient has a airway management if necessary, oxygen or maybe endotracheal tube, oxygen is necessary, or other supportive care as in any case of seizures, like the patient should not injure him as such, the body has to be protected, the child has to be kept in a position where a self-injury may not be occurring as such, and if necessary anticonvulsants are given. And in children particularly febrile seizures, the usual choice of the drug given is a rectal diazepam suppository given at 0.5 milligram kilogram body weight, or oral at 0.4 to 0.5 milligram per kilogram, or even intranasal are effective, and it can be given at home for lasting less than or 5 minutes as such. The other options which you have to do are cold sponging and the cause of fever has to be assessed. So like most commonly, children would have pharyngitis or otitis media, other viral fever, gastroenteritis. These are the common issues, and they have to be identified. And if there is a need for treatment, they have to be given. From our clinical point of view, Tribunakirtiras and sarsaparilla would be good enough in a simple febrile seizure, and if necessary, the diazepam rectal can be given to avoid the attacks if there is a persistent attack for more than 5 minutes. A simple seizure lasting for 2 to 3 minutes doesn't require even that kind of a treatment. Now, the important are if the patient has such a febrile seizure, when the patient requires admission in the hospital and investigations. This is an important clue. If the patient has more than one seizure within 24 hours, if the patient's clinical status is unstable, that's the blood pressure, respiration is affected. If there is a lethargy, a dullness presenting even after the seizure has recovered for more than 3 hours, or if the condition in the home is not reliable, or that you are not able to know the follow-up care, in such conditions the patient may require admission, investigations, and then after the investigation the treatment has to be given accordingly. Now the other possible conditions which can occur, we will be discussing them separately when we go into the other conditions which produce the seizures. So that's one of the conditions. Febrile seizures, there again we have referred to simple febrile seizures. Then another variety is what we call as a benign neonatal convulsions. Now this is a simple theoretical difference, but has a significance in the total approach to the treatment. A simple febrile seizure doesn't require a prolonged treatment, doesn't require a prolonged anticonvulsant treatment. Only during the episodes of convulsions, the anticonvulsant drug may have to be given. There is no need of prolonged treatment in a simple febrile seizure. The only issue is the pathology which can produce the fever have to be corrected properly. Whereas the other varieties, and one of the other varieties is benign neonatal convulsions. Benign neonatal convulsions are defined as seizures with the onset after birth through up to 28 days. Up to 28 days. Whereas if it is above 28 days, we consider this as a other kind of convulsions, and the patient may have to be treated accordingly. Either it could be febrile or non-febrile conditions, and otherwise healthy child and with no other medical or neurological pathology. And these are considered as genetics. It's also called as genetic benign familial neonatal convulsions, and the genetics are even identified now, and it's considered to be due to inherited property of autosomal dominant, and the pathologies are they now defined as either there is a abnormality of the potassium channel or abnormality of other ion channels, or there is an abnormality of neurotransmitter development, and the possibility of the risk of seizures developing later in life, which may be categorized as epilepsy, and the standard protocol of the treatment of epilepsy may have to be given in around 11 to 16% of such patients who have developed neonatal convulsion. So a convulsion occurring before 28th day of the birth, where there may not be a fever, single or multiple, you have to consider this as a neonatal convulsions which need to be investigated. And when there are no other neurological causes and the patient has a convulsion, that's categorized as benign neonatal convulsion. And the benign neonatal convulsions, the risk of the child developing the seizures for the whole life would be around 11 to 16%. Then the criteria for benign idiopathic neonatal convulsions, the infants should be after 39 weeks, that's a full term. They have to be born after full term, completely viable full term, and Apgar score should be high as such. It should not, the children who have a low Apgar score, they may have a convulsions due to other causes, neurological causes, so cannot be categorized as benign. So in a newborn, if the child has convulsions, you have to be extra careful. Newborn convulsions could occur due to lots of other neurological pathologies, and in such conditions Apgar score could be lesser. So if the other score is higher, at least 9 or more, then it has to be considered as the possibility of that benign neonatal convulsions. If it's otherwise, you have to go for thorough investigations. And if the seizures have occurred, seizure-free interval between birth and the onset of seizures, like that should be a gap. The moment the child is born, if the child has developed seizures, then that has to be considered as a critical issue which needs investigation. If there is a time gap, maybe a few hours or few days for the seizures to occur, then it is considered as a possibility of benign lesions. If the child has clonic or apneic seizures, then it also has to become clonic, the typical spasm occurring. It could be a sign of the benign conditions. And if there is any other etiology or clinical investigation, if no other specific cause is found out, the other investigations like lumbar puncture has to be done in such conditions. And if the CSF is normal, then there is no other issues. Or if the child has a normal intellectual and developmental course, and if there is no seizure up to around 28 days, then if the normal laboratory findings are suggestive of that, in such conditions, it has to be considered as a benign familial history. Or if there is a family history of newborn infantile seizures, it has to be considered as the benign condition. A benign condition also can be confirmed with the electronic EEG, and the benign neonatal convulsions would be presenting with the typical wave pattern where the theta waves of 4 to 7 hertz can be seen. These type of low grade theta waves would be seen. That's the typical EEG finding, which confirms the benign condition. So all that challenging would be to decide which of the condition has to be considered as benign condition, which of the condition needs to be considered to be of critical type, and then plan the treatment. The treatment would be, in case of a proved benign condition, there is no need to prolong the anticonvulsant treatment for beyond 10 days. So during the attacks, benzodiazepines, phenobarbital or levetiracetam or phosphophenetine, these are the preferred drugs. Most of the times now these days it's a levetiracetam or levera tablets are they usually given, or syrup is given at a low dose, and generally medicines are not required beyond 10 days, and only 11 to 20% patients will have epilepsy in later life. So there you have to follow the protocol of epilepsy. When we come across such patients, I would be prescribing sarasvarista for long duration, just low dose, which can help in prevention of the other complications. Now that's about certain of the newborn or pediatric conditions which are presented. Now pediatric presentations which present with the organic pathology like impairment of the nerve tissues or maybe other conditions, we will be discussing separately. Now among those pediatric conditions which can present with the more serious issues are meningitis, the next common condition, particularly which you have to be very careful in a patient with the febrile seizures, particularly febrile seizure conditions where the patient has a fever. Assessment of the condition to rule out the meningitis is absolutely essential. If there is a confusion, then there could be significant changes in the outcome. Now, meningitis is a clinical syndrome characterized by inflammation of the meninges. Again, that could be classified as a meningitis when the inflammation is limited to only the dura mater, arachnoid and pyometer layers. Encephalitis is when the brain tissue also is involved. This difference is mainly from the academic point of view. Practically, every patient of meningitis also has to be considered as a potent case of encephalitis, and every patient of encephalitis would be considered to have a meningitis earlier. So, from the clinical point of view, these differences would be, of course, suggestive of more serious issues, but to consider or to keep these two watertight cases or watertight compartment cases, to consider these two conditions as two absolutely separate entities is not correct. Now, the clinically again meningitis again maybe subclassified according to the presentation as acute meningitis, chronic meningitis, aseptic meningitis, and recurrent meningitis. Now, even the acute meningitis, you have subtypes like bacterial, viral, fungal, or tubercular, so on. So, the classification of the meningitis is quite elaborate. In the beginning, we will start with the bacterial meningitis, and then because that's more common, then the other varieties will continue in the coming sessions as such. Now, bacterial meningitis, the mode of spread is either it could be invasion through the bloodstream. That's mainly the child may have some other source of infection. Either it's bacterial as viral, fungal also. In such conditions, the child may have some source of infection somewhere in the body, and it may result in bacteremia. That's a very virulent infection, which can again reach to the meninges, and meningitis could occur. Or a retrograde, that's through the nose, particularly children who have nasal infections or the other involvement of the nerves, it can result in the neuronal this spread. So, in a patient of meningitis, you have to identify these primary causes, and the organisms which may spread through this route are Neugleria or Draxpoma, or direct continuous spread. Now, this is from our clinical point of view, this is more common. Children who have upper respiratory tract infection like sinusitis, otitis media, or congenital malformations, or trauma, head injury, these are patients who had intracranial surgeries, that's intracranial manipulations, that was a spelling error. These are also could be the other causes. So, when the patient has some external possibility. Patients who have chickenpox or measles, etc., exanthemas or exanthematous fever conditions, chickenpox, measles, etc., or the patients who have contact with the febrile illness, they may develop the meningitis commonly. Symptoms of pericarditis, myocarditis, or conjunctivitis, or fluorodynia, herpangina, hand mouth disorders, they also have a high chance of the meningitis. Classically, clinical evidence of meningitis is we also consider this particularly bacterial meningitis. Now, in the beginning, we will limit to bacterial meningitis in the beginning, then we will go into the other later. The classical clinical triad, the signs are high fever, headache, and neck stiffness. Neck stiffness is one of the very critical issue. In children, very small children, if the child has not become dehydrated, a bulging of the fontanella could be seen. Now, important, bulging of the fontanella is considered as a clinical sign of meningitis. But if the child is dehydrated, this sign may not be seen even if the patient has a pronounced meningitis. So, that's not a very dependable sign, but when the sign is present, that has to be identified. In neonatal children, there is another classical clinical sign that's called as paradoxical irritability. That paradoxical irritability means when the child is kept on its own, the child may be quiet, but when the child is held and moved, the child becomes more irritable. Usually it is the other way. A child becomes more irritable when it's kept below, or when the mother doesn't hold it. When the mother holds, the child usually gets pacified. This is the usual situation. But whereas in case of meningitis, the paradoxical irritability would be the other way. Holding and moving the child may produce more irritation, whereas keeping the child below or away from the mother may produce some comfort. That sound produced with a cry also is classical. High pitched cry is there will be a certain change in the pattern of the cry. Tone of the muscles also could be reduced, which could be the other sign seen in children. In addition to these, other clinical symptoms which could be seen in a case of meningitis are nausea, vomiting, then photalgia, that's or photophobia, discomfort when the patient looks into bright lights, sleepiness, confusion, irritability, delirium, or even coma can occur. Seizures also could occur as the clinical signs. In a chronic bacterial meningitis, in addition to these, there could be symptoms like lymphadenopathy, papilledema, and meningismus. That's the same headache, stiffness, and photophobia. And the cranial nerve palsies could occur, or neurological signs could occur. The meningeal irritation can be confirmed by clinical signs, the cervix and Brudzinski sign, which is a quite important issue. When you extend the knee, keeping the hip flexed beyond 90 degrees, the patient would have more pain or not. It may not be possible. That's called as Carnage sign. Brudzinski is when the neck is bent, the hips and knees flex. These are the signs of meningeal irritation, and these the classical clinical signs of meningitis, bacterial, particularly bacterial meningitis. Now, complications which can occur due to the acute bacterial meningitis are quite significant. The complications could occur as the damage to the cranial nerves. It could be any nerve, more commonly cranial nerve, presenting with the hearing loss. Or CSF pathways would be obliterated, causing hydrocephalus in due course of time. Or vasculitis and thrombophlebitis, causing brain ischemia, or even the peripheral thrombophlebitis could occur in such conditions. Hypertension, hypoxemia, hyponatremia, arrhythmias, stroke, or the aggravation of previous chronic diseases could be the other complications which can be produced due to meningitis. A patient of meningitis, even if the patient is treated, later on there could be these complications developing, and during the whole approach to the treatment, all these have to be tackled directly. Immediate complications of meningitis are mainly septic shock or disseminated intravascular coagulation, where clotting could occur throughout the body, anywhere in the organ, and even gangrenes could occur. Coma with the loss of protective airway reflexes, where the patient may need airway supplementation, even tracheostomy may be required. Seizures, and in about 30 to 40% of the children, and in 20 to 30% of the adults, seizures would be the common signs. So, as a differential diagnosis of a febrile seizure in children, meningitis comes number 1. Cerebral edema or arthritis, pericardial effusion, hemolytic anemia also could be the complications as a meningitis as such. Delayed complications which can occur after the child has recovered could be decreased hearing or cranial nerve abnormalities, persistent seizures or multiple seizures, focal paralysis some areas of the body, effusions in the subdural area which can produce a space occupying signs, hydrocephalus, intellectual deficiencies, ataxia, blindness, Barthel's prediction syndrome. That's a sudden failure of adrenal gland and collapse. The child may even sudden collapse could occur in case of the patients who have recovered from meningitis due to sudden failure of adrenal gland, adrenal secretions, and that's called as Barthel's prediction syndrome. Septic thrombosis or of the venous sinuses, peripheral gangrene also could occur. There could be brain parenchymal changes, which can result in sensory or motor deficits, cerebral palsy, learning disabilities, intellectual disability, cortical blindness. Seizures can be persistent as a result of the changes in the brain. Intracranial pressure and cerebral fluid can increase, which can result in cerebral edema, and it may develop into ventriculitis, empyema, cerebritis, or abscess formation. These are the pathological changes which could be seen in acute meningitis in when you go for the investigations. Now, in all cases of suspected meningitis, study of cerebrospinal fluid is one of the important investigations which are to be done, and the CSF fluid analysis is very dependable and one of the essential investigation which has to be done. And the important differences between a normal and bacterial meningitis, viral meningitis, fungal meningitis, and tubercular meningitis are very clearly seen. In the normal, there could be a clear CSF. In a bacterial meningitis, it could be cloudy or turbid. In fungal meningitis, there could be a fibrinous web as such. Tubercular meningitis, again, it could be cloudy or viscous, thick as such. White cells, that WBC, very high in case of bacterial meningitis, it could be more than 50,000 or around that. And in fungal meningitis and tubercular meningitis, maybe or viral meningitis, moderately increased, whereas the normal would be less than 20. Predominant white cell type. Now, in case of viral meningitis, lymphocytes would be seen, whereas in bacterial meningitis, neutrophils would be seen, which is very classical. Then proteins, in case of bacterial meningitis and tubercular meningitis, it will be very high, whereas the normal would be less than 1. And the glucose level would be low in case, this is very classical, the glucose level will be very low in case of tubercular meningitis, bacterial meningitis, very low in tubercular meningitis. Normal would be around 60% of the plasma glucose level. So you have to have a blood sugar level, and the normal in the CSF would be 60% of the blood glucose level. In case of bacterial meningitis, it will be around 40%, and in case of tubercular meningitis, it will be less than 30%. The CSF pressure is high in the bacterial, fungal, and tubercular meningitis, whereas viral meningitis is not raised much, maybe slightly higher. So the assessment of the CSF is one of the important issues. Then other investigations which are quite essential in a case of meningitis would be serum electrolytes to determine the dehydration complications, which can also result in antidiuretic hormone pathology and Bartter-Fredrickson syndrome, which can produce sudden death. Now, serum glucose, again, as I told you, it's to compare with the CSF. And creatinine levels and liver functions, HIV testing are the other issues. Imaging studies, MRI and CT scan are very critical in case of diagnosis of the meningitis, and the signs which could be seen in case of the CT also could be wide varying. The commonest sign of CT sign of meningitis is what we call as a watershed infarcts. There would be multiple scattered dots of infarcts seen in the brain tissue, both in the cortex area as well as the medullary area. The whole brain tissue looks like somewhat having a spongy appearance, and this is called as watershed infarcts, as if it is having multiple water drops. Then the other signs could be, there could be a lacunar infarct, a permanent lacunar infarct, as well as there could be a subdural effusion. Now, subdural effusion, presence of the fluid in the subdural space, producing that gap between the skull and the brain tissue, is suggestive of a more serious involvement, critical involvement, and the child has a poor prognosis there, and the treatment has to be more energetic in such conditions. So, in a typical meningitis, you may have a watershed infarct, a ganglion lacunar infarct in some areas, and there could be subdural effusion. Or there could be ventriculitis. Again, ventriculitis also is another of the sign where there is an obstruction to the CSF flow, which again is very critical, where there could be ventricles become dilated, the whole of the ventricles become dilated, and then produce a compression of the nerve tissue, and this also would be very critical, may produce a poor prognosis as well as long lasting complications. Or abscess formation. A meningitis can result in a localized abscess formation, which essentially requires a surgical intervention maybe, and again the makes the prognosis poor. And subdural empyema, instead of limited abscess, there could be pus formation in the subdural area, and it could be corrected over there, and this also is suggestive of a critical complication in the tissues. And the empyema also can produce a shift of the midline, producing the compression of the other side of the brain, which again makes critical. So in a case of meningitis, a series of investigations like MRI or CT repeatedly may be required to confirm about these pathologies, and that has to be treated energetically. Poor prognosis would be if the patient is in a older age. Now, though we are considering pediatric conditions, meningitis can occur any condition. So, if the patient is at older age, the complications could be more, prognosis would be poor. If the patient has tachycardia, if there is a low Glasgow coma scale or cranial nerve palsies, or if the leukocyte count in the CSF is more than 1000, then if there is a gram positive cocci in CSF gram stain, that suggests you have a poor prognosis. As far as the treatment is concerned, the treatment would be based upon the possible type of the organism known. So ideally, it has to be according to the type of the organism and sensitivity tests. But because it's an emergency condition, empirical antibiotic use is suggested, And the general protocol of selecting these empirical antibiotics is based upon the common type of the organisms in certain age groups or in the patients who have a immunocompromised stage. The common type of the organisms in children of age of 0 to 4 weeks is streptococci, mainly gram-positive, Escherichia or Listeria. And the usual empirical antibiotics described as per the antibiotic policy is ampicillin plus cefotaxime or an aminoglycoside like gentamicin. Then age 4 to 12 weeks, the organisms could be E. coli, Haemophilus or Neisseria along with the Streptococcus. And in such conditions, the suggested empirical antibiotic is vancomycin plus cefotaxime or ceftriaxone. 3 months to 18 years, the common organisms are meningitis, Neisseria meningitis, or Streptococcus pneumoniae or H. influenzae, where again the suggested antibiotics are vancomycin plus ampicillin plus multiple antibiotics are suggested as empirical antibiotics. Now, these suggestions of antibiotics are important now because antibiotic policy is becoming more rigid now, and hence these are quite significant issue. So that's about the selection of the antibiotics. But ideally, the correct antibiotic has to be selected after having the culture and sensitivity tested. A sensitive antibiotic has to be used as such. Uh, that's about the empirical. The other part of the treatment is to prevent the complications. If the child has, or if the patient has signs of intracranial pressure increase, which is common complication, and hence it's generally prescribed in case of meningitis, furosemide IV or mannitol 1 gram per kilogram body weight IP. For the patients with hypoxemia, the hyperventilation with oxygen. For the seizures, lorazepam or phenytoin or phenobarbital are given. Steroid therapy is the other benchmark tool to save the patient from other complications like mainly dexamethasone at 0.15 milligram per kilogram every 6 hours for 2 to 4 days till the patient has recovered from the acute episode. That's about the treatment for the meningitis, with bacterial meningitis. With this, we will conclude today. We will continue with the other conditions in the next session. If there are any questions, we will try to answer. No questions, so fine. We will stop today. We will continue with the other types of meningitis, tubercular and other meningitis, and next going to the epilepsy. Right.